Hey, good morning, everyone. Thank you for coming. Thank you for coming. I will not belabor the introduction of George Annas and Michael Groden because it would take me until day after tomorrow to just scratch the surface of their curriculum vitae. These men have done so much in the field that we will be exploring today and in many other areas. They are both professors in the School of Public Health, and in the case of Dr. Groden, he's also professor of medicine and psychiatry. They have written so much, so many papers, so many books that they have edited, and so many lectures that truly it's remarkable the career that they've had. They specialize in the areas of ethics and the law as it applies to medicine. And they went to school at prestigious institutions. In the case of Mike, whom I've known for so many years, he did his college at MIT and his medical school at Einstein. And I'm surprised that George, after having done college, law school, and a master's in public health at Harvard, is here with us. But it's great. It's great to have him.
Then he came up in the world.
That's right. Exactly.
I must confess that what sparked my interest in this topic was the fact that my father passed away several months ago. And to be perfectly honest, I was not prepared as an anesthesiologist, as a physician, certainly not as a son, to deal with his passing, which was traumatic from the point of view of medical care in the Dominican Republic. He died surrounded by his family, but end-of-life treatment there is not as you would hope it would be. And I know that we have difficulty even here addressing this problem. The difficulty that I had specifically was related to the administration of analgesics and comfort measures at the end of his life. Anesthesiologists in particular do not deal with death very well. In fact, we spend most of our careers, and most of us anyway, except for the folks that deal with critical care, preventing people from dying. And the last thing that we want to face in an operating room is death. In fact, sometimes we deliberately keep the patients alive so that the intensivists in the intensive care units deal with that. So it is not what we come here to do among all specialists. And then, of course, last year was a horrible year for my colleagues because Glenn Stanley lost his mother, and Sanjay Jain, who is here, lost his father and a brother, and Alex Kotov had his father-in-law died in his house, and others had traumatic experiences. So I thought that it would be a good idea on a personal level, but also as physicians, to have these two gentlemen discuss this topic that inevitably we will face in our personal lives and in our professional lives. So please let's give them a warm round of applause. And they take it from here. Maurice, morning.
What we really want to do is have a dialogue or discussion based on issues you want to talk about or cases you want to talk about. I thought I'm going to have Dr. Groden give a couple-minute introduction about the subject matter and also the fact that there are some guidance at the hospital of hospital policies.
So I really only want to take a few minutes just to highlight some general points that may kirk your imagination and ask questions and deal with cases. But I've been on the faculty here for 38 years, and I'm the medical ethicist for the hospital. I'm a physician, and I've been doing medical ethics consultation here for 38 years, back to the city hospital days. So I've had a lot of experience dealing with patients and ends of life issues in particular. I would say that over the years, I've probably done 1,000 consults on ends of life issues, and 90% of the issues are communication problems. So the ethics problems are dilemmas because they're dilemmas, and they're supposed to be dilemmas. It's not clear what to do. There's good, strong, and persuasive arguments both for and against the various choices, which is why everybody's so anguished. But in my experience, most of the time, the problem is communication. The ethics problem is going to be there, and that's to be dealt with. But the real issue is that nobody's talking to each other, and we have to, basically, the process of getting people together in one room and opening up the conversation like we're doing here is really half the battle. Is getting everybody in one place to ask their questions and to deal with the value clarifications, what the options are, what the diagnosis is, what the prognosis is, what the risk benefits alternatives, what will happen with treatment, what will happen without treatment, and then dealing with who should make the decision. And we can have a conversation about that. Obviously, an adult, competent individual will make their own decision about refusing treatment for sure, and there's almost no limit on what you can refuse. Increasingly, over the years, the residents can't believe it, but originally when I came here, you couldn't get somebody off a ventilator. And today it's the opposite. Many people are demanding treatment. I no longer have the issue of dealing with a consult for somebody who's demanding refusal of treatment. It's now more people who are demanding treatment, and there's some concern about what's appropriate, what's achievable in terms of the goals of care, and what's appropriate, and how to manage that particular situation. But I'll give you the cost of the ticket here. I'll give you the whole thing, and the price of admission. If you do 4 things, these are what I would suggest in terms of the most important aspects of what you can take away from today. I would say you should always aim to benefit the patient. Always aim to benefit the patient. It's when you start to aim to benefit the institution, the doctors, whatever, it's when you get into trouble. So always aim to benefit the patient. Get voluntary, informed, and understanding consent from the patient and or their family where appropriate. Or if they can't give that consent, then go to the proper surrogate who has a relationship with the patient. And that's where advanced directives come in. And we can talk about those healthcare proxies, whether you can dismiss a surrogate. But those are issues. Communicate whatever the plan is with all the parties that be, and then document it. Document it not for medical legal purposes, although that's helpful also, but so everybody knows what the conversation is and what's going on. That's about all I want to say. We'll talk more about advanced directives. But the important thing, probably the most important thing I can do today is say that I get calls, not so much from anesthesia, but from surgery and from medicine, asking about questions about withdrawal and withholding of life-saving treatment or limiting treatment. And there are policies